Welcome to today's discussion, which is going to be on antibody mediated rejection. Let me just share my screen. Okay, can you see? Can you all see my title slide?
Yes.
All right, very good. So antibody mediated rejection obviously is an important disease entity, not just because of the burden it portends on the transplant population, but also because by understanding this, we understand the transplantation immunobiology. And if we understand transplant immunobiology, we can then modulate our therapy appropriately to various patients. Before we start, I'll request a moment of personal privilege. This is Brigadier Shaheen Moeen. We lost her last week to COVID. She is a titan in nephrology in Pakistan. A whole generation of physicians in the armed forces have been trained by her. She was my mentor. I worked very closely with her for several years when I was training in Pakistan. And we've lost truly one of the trailblazers of nephrology in Pakistan. She also shattered many ceilings. So may she rest in peace. And in whatever we do, we carry forward a little bit of the flame that she ignited in us. So I'm going to start by portending a couple of cases, and then we will try to dissect them as we go through our conversation. So this is a young 38-year-old Hispanic gentleman with diabetes and chronic kidney disease who received a living unrelated kidney transplant as part of a kidney pair donation arrangement. This was several years ago. His pre-transplant immunological studies were negative. Cross-matches were negative. He had no DSA determined on flow PRA. He was induced with Campath and achieved profound lymphocyte depletion, as is almost always the rule. Was started on maintenance with Prograf and Cellcept. He had initial allograft function. By post-op day 4, his creatinine was down to 1 milligram per deciliter, and we were actually getting ready to discharge him. But in the afternoon that day, his urine output dropped and his creatinine had gone up to 1.4. And by that evening, his creatinine had gone up to 3 milligrams per deciliter despite adequate fluid resuscitation. So this is post-op day 4 to post-op day 5. On post-op day 4, he had an HLA-A52 antibody detected, which is directed at the donor in an MFI of about 16,000. So that's 4 days after transplant. He has a donor-specific antibody at an MFI of about 16,000, whereas his pre-transplant studies were all negative. How could he develop this antibody so quick? Contradistinction, there's this young patient, she's about 40 years old, and for the sake of these conversations, we kind of smudge the ages and sex and sometimes other details to keep anonymity. But this is a 40-something-year-old Caucasian female, type 1 diabetes. She received a simultaneous pancreas and kidney transplant in December of 2017. She received a total induction dose of thymoglobulin of 6 milligram per kilogram. She was started on triple immunosuppression for maintenance. She was non-compliant, and we call it Aphrodite's revenge because each time she would have a fight with her boyfriend, she would stop taking her medicines, which was kind of perplexing to me. I'm like, do something to the boyfriend. Why do you stop taking your medicines? But in any ways, she had a Banff 2B acute cellular rejection in 2018. This resolved. Now, at that time, she had developed a class 2 DSA, but her biopsy had absolutely no stigma of an acute cellular rejection. And then in June of 2018, now she's out of insurance. She's non-compliant again. She was admitted with elevated creatinine and lipase and undetectable Prograf levels. She has a DQ6 antibody with an MFI of 23,263. So between the two cases, is the mechanism of generation of the antibody the same? And that's what we will discuss. This is a gentleman, we call him Bacchus's curse because we all suspect that he's a closet alcoholic. We've never been able to prove it, but he is a 40-something-year-old Hispanic gentleman, sorry, Caucasian gentleman, who underwent a living unrelated kidney transplant in 2017. He was induced with Similac. I'm sorry, this is a typo. He did not receive thermoglobulin, but maintained with Prograf, Myfortic, and prednisone. He has had stable proteinuria of 500 milligram per gram since the time of his transplant. In January of 2020, proteinuria increased to about 2 to 3 grams per gram, and it had been kind of going up the past couple of months. We checked the cell-free DNA on him, and the signature was high, in fact, very high for comfort. And he had a new class 2 DSA. It was a DQ2 antibody with an MFI of more than 20,000. So why is he developing an antibody now? We did a biopsy on him, and he had an ABMR, which showed actually fairly active microvascular injury, and we'll discuss what microvascular injury is, but didn't have a lot of chronic change, so that was good news. So his complexion of developing antibody-mediated rejection is very different from the previous 2 patients. And finally, the last case we would like to discuss, I call it Athena's wisdom, not because of the patient's wisdom, but because of my partners who picked it up. This is a young lady in her 30s, status post a living unrelated kidney transplant in March of 2018. She was induced with Campath and maintained steroid-free and Prograf and MMF. Her baseline creatinine had been 0.9 to 1.1, and AlloSure was drawn as surveillance, and it was very high, 5.4%. Her creatinine was about 1.1 milligrams per deciliter. DSA was negative. Her BK-PCR and CMV-PCR were negative. So why is she developing this high AlloSure? And we'll go about that as well. So this is my favorite picture. Where do antibodies come from? We all know that B cells are generated in the bone marrow. They exit the bone marrow as precursor B cells and arrive in the secondary lymphoid organs, the spleen, lymph nodes, etc. And here, based on what type of antigenic stimulation they get, they can actually turn either into follicular B cells or develop a marginal B cell reaction. Now, for most infections, the marginal B cell reaction would generate short-lived plasma cells. They'll make antibody, usually limited to the course of the infection. So if you get a sore throat or if you get a pneumonia, this is what you're probably going to get. With persistent antigenic stimulation and presentation of particular types of antigens in the context of MHC2 by T follicular help cells to these follicular B cells, you enter into what is known as a follicular reaction. And that's where things start getting interesting. So these responses to antigens take 2 phases. The first phase is where the naive B cell, which is resting in the secondary lymphoid organ, is presented this antigenic material in the context of an MHC2 molecule, and these guys then start getting activated. When this happens, they express CCR7 and EB12, which are chemokines that directs them to the TB border in the lymph node. Here they meet with T follicular help cells, and this is becoming more and more important, as we will talk about in the later part of the talk. When the prime B cells talk to the TFH, T follicular help cells, they become activated and they start proliferating. After this phase 1 of proliferation, they can undergo 3 different phases. They can become a germ cell independent memory B cell, which again is the fate in most of the infections. They can develop a short-lived plasma cell, which is again seen in most of the infections. But in certain circumstances, they are trafficked to the germinal center where they proliferate, undergo somatic hypermutation and class switch. So their surface antibody switches from an IgG to an IgM, IgM to an IgG. And then they have these three fates after phase 2. They turn into memory B cells, they turn into long-lived plasma cells, or they go back to the germinal center dark zone and perpetuate this proliferative response. So now, as an outcome of this entire process, you've got these two things sitting around. The first is long-lived plasma cells, which phenotypically are CD19 negative, CD138 low, CD38 high. And these usually traffic to the bone marrow where they sit in. So if somebody has had, for instance, vaccination to COVID, which is a very, very hot topic, traditional vaccination to COVID, the COVID virus is going to be unpacked by the antigen presenting cells. It will be presented to the B cell receptor. There will be T and B cell help. And eventually, after a germinal cell reaction, you have long-lived plasma cells that will be shuttled to the bone marrow, where they will send out small amounts of antibody or large amounts of antibody, depending on the degree of stimulation. And you'll have memory B cells ready to pounce on the virus should the virus show itself. So that's the idea behind vaccination, and HLA encounters are essentially like vaccination of the immune system with HLA material. Now, why is this important? So this is the two-wall concept of immunity in these circumstances. Plasma cells have a very narrow band. Their repertoire is restricted, so they have very specific antibodies. So very high specificity, very high affinity antibodies, which actually narrows down who they can actually stop. So if the virus is pretty specific to what the antibody sensitivity is, if this was a measles vaccination and it's a measles virus that tends to show up, it will be blocked by this. But if the virus is crafty, and the COVID virus is a crafty virus, it may actually go right past this first wall of defense, which is where the memory B cells will pick it up. And the repertoire of memory B cells is orders of logarithmic orders of magnitude broader than plasma cells. So they have more versatility. So they can still block it. So that's the second wall which hits your virus. And if the virus evades that, then you actually go in and start generating a response from scratch. So if somebody gets COVID now, if you check their blood after 12 weeks, you'll find that there's IgG there, and the IgG is there because now there's long-lived plasma cells that have been generated, which are slowly releasing that antibody. So type 1 or early AMR, which is because of preformed antibody, is something like this. So you've had previous exposure to the HLA molecule, you develop a response, you develop these long-lived plasma cells in the bone marrow, and you develop memory B cell phenotypes. So let's suppose we were talking about our first guy who on post-op day 4 suddenly mounted that response. More than likely he had had exposure to the HLA antigen of interest in the past. The reason we didn't pick up any antibody on our pre-transplant testing was that the long-lived plasma cells had burnt out by that time, or the level of the antibody that they were making was very low. So you've read about this in the COVID literature as well, that sometimes you lose this IgG, and that is how you do that. The plasma cells don't last long enough. But he probably did have memory B cells in the system. When the memory B cells see the antigen of interest, they can mount a very, very vigorous response. And as you can see in this picture, after a primary exposure, it takes quite a bit of time to start launching antibody. But when you've got ready memory B cells, they quickly turn into plasma cells, and within a matter of hours to days, will turn out sheets of plasma cells. I've seen people go from virtually no antibody to an MF5 20,000 in 72 hours. So that can happen really, really fast. And this is how our first guy developed the process. Now, how does this go on? Because you've got those preformed antibodies, but what if you have no preformed antibodies? Then you develop an antibody response to these antigens, because these antigens are still surveilled by the patient's own immune system as foreign. And so if you don't have enough immunosuppression, and this is usually the scenario in which you develop a late antibody mediated rejection, is that your immunosuppression, either prescribed or because of non-adherence, was not up to scratch. It wasn't enough to hold off the immune system. And so now your own antigen presenting cells are picking up donor HLA material, presenting it to your T helper cells, and launching a pretty conventional immune response. So in this circumstance, so in the first circumstance where you had sheets of antibodies within the first few days after transplant, you were tapping into this reservoir. But in the second case, you're actually generating a response through the entire phase 1 and phase 2 processes. And in these cases where you've got indirect allorecognition late after transplant because of under immunosuppression, either prescribed or adherence related, you can actually have combinations. You can have CMR alone, you can have a combination of AMR and CMR, or you can have AMR alone. In the response to pre-existing antibodies, usually what you see is a very pure acute antibody mediated rejection. But when you're seeing de novo immune response, sometimes you see mixtures. And so these are the phenotypes that we can tease out for antibody mediated rejection. When they're related to pre-existing antibody, it could be early. So like in our patient that we discussed, within the first few days after transplant, or it could be late. When it is early, it is usually a ABMR, usually class 1 antigens, usually C4D positive. In its most severe forms, it can present with a TMA. It is associated with ATN, and we'll see why ATN happens in these cases. When it is late, it can present as an active or a chronic active ABMR, and Dr. Latif will kind of go over, when we get to the path part, what these things are. When we are developing de novo antibody and developing a de novo response and generating an immune response to that, due to that, it's usually a late ABMR, more than 30 days, active or chronic active ABR. These are C4D variable, and coexistent T-cell mediated rejection is common. Chronic ABMR is usually more than 30 days out, usually more than 6 months out, but I've seen it before that. And the hallmark of this is transplant glomerulopathy, which we will look at when we get to path. So the humoral theory of transplantation is as old as transplantation as well. This picture, which I don't know why is kind of ghost-like, but is a picture of Peter Gorer. He actually is the guy, he's a Brit, and he discovered MHC2 in mice. He was an early champion of ABMR, and he died in 1961, unfortunately, of lung cancer. He was a very heavy smoker. In the middle is his colleague and arch nemesis, Peter Madower. Based on all of his observations on the Koch reaction in animals, he thought that all rejection processes are cell mediated, which obviated the need for antibody in his construct. So for a fair amount of time, it was thought that antibodies are not relevant in transplantation, which was a little bit of a cognitive dissonance because this is Peter Terasaki, who actually used to work for Peter Madower, but then he was convinced that antibodies are important. And this is the guy whose paper we all read from 1969 that looked at preformed antibody and developed the first cross-match, which actually helped propel transplantation into era. Reason had this problem following our paradigm. We have the specific antibody, which leads to endothelial injury, and that leads to then morphologic effects and leads to various types of rejection. The problem was we could see DSA, we could see morphologic effects, we could also see endothelial injury, but we could not prove that there was DSA there because there was no way for us to demonstrate that important step of the antibody actually causing damage to the endothelium. And this was actually finally surmounted in 1993. This is a paper from Germany, where they actually looked at C4D. So essentially what happens is when your antibodies, HLA antibodies, join with the HLA antigens on endothelial surface, they fix complement. So C1q is fixed, and we know that C1q are S, and then C2 and C4 are activated. C4 is cleaved from C4 to C4a and C4b. Now, this C4b usually washes off, but there is a protein on the surface of the endothelium, MCP, which is CD46. We all know it in our studies of HUS because mutations in MCP actually give us some phenotypes of HUS. But the MCP converts this C4b into C4D, which is the thioester, and anchors down in the endothelium. And we can then stain for it. So if you're seeing C4D on the endothelial surface, you work it back and say, okay, this is because there was C4b activated, and the C4b was there because C1q was activated, and the C1q was activated because an HLA antibody actually was attached to the endothelium. So you can't find this antibody, but you can find C4D. So that's your smoking gun. And so you can do it through immunofluorescence or immunoperoxidase, and Dr. Latif will teach us a little bit about that as well. So our first paradigm of how these antibodies actually cause trouble is through complement activation. So you've got C1q, which is the first protein of the classic complement pathway, which then leads to the generation of your C5 convertase eventually. And the membrane attack complex is generated, which causes problems on the endothelial surface and causes damage to the endothelial cells. But this also leads to generation of these anaphylotoxins, which actually generate inflammation. The subclass of IgG is very important. So some IgGs like IgG3 are very good at fixing complement. IgG4, not so much. So this is why you don't see classic complement pathway activation in, for instance, membranous, because the antibody there is IgG4. And so the density of HLA antigens matters. The cross-linking capability matters. So there's a lot of factors beyond just having a DSA that determine what is going to happen. So complement activation is one. So you've got this antibody which is attached to the endothelial cell through the HLA molecule. It's fixing complement, and you'll have these complement proteins causing local endothelial damage. But then other things happen as well. These HLA antibodies can actually invite mononuclear cells, so some of the innate immune system cells attached to them through their Fc gamma 2 receptors and cause trafficking. So you can have monocytes and macrophages traffic into the area, and you can actually have outside in signaling by the combination of HLA antibodies to the HLA antigens. Which looks something like this. You've got HLA antigens, which are cross-linked by the antibody. That leads to internal signaling. We're not going to go into the detail of what this signaling is, but suffice it to say that traffics several proteins onto the surface. So your ICAMs and your VCAMs and so on and so forth, which actually make the endothelial surface very, very sticky. So you've got all of this going on. You've got direct complement mediated damage, which is going to fix C4D, but the antibodies can do other things. This essentially comes in the realm of antibody dependent cell cytotoxicity. And then you've got direct outside-in signaling of the endothelium. So now imagine this, you've got this small little capillary, peritubular capillary, shall we say, and you've got this endothelium which is active and angry and very sticky, and it's causing all these inflammatory cells to come in and traffic in. So if you have this going on, then these peritubular capillaries and the glomerular capillaries are going to look very inflamed and very angry. So this is what happens in antibody-mediated rejection. You've got a DSA, which could be because of a pre-existing process or de novo generation. You can get endothelial injury, which could be because of complement-mediated issues or non-complement-mediated issues. And then you get some morphologic effects of that. And for the morphologic effects, I'm going to invite Dr. Latif, who will kindly walk us through the pathology.
Thank you, Irfan Bhai. So we in pathology tried to classify, use the Banff classification, which is very easy for us to explain the different types of rejection. So in antibody-mediated rejection, the very first thing, very early antibody-mediated rejection is when we see acute tubular necrosis. That is the very first indication that there is something going on with this patient, along with some peritubular capillary dilatation, as you mentioned, and some neutrophils. This is a picture of basically acute glomerulitis. You can see part of the glomerulus on your left-hand side is normal. And where the arrows are, they are pointing some inflammatory cells in the capillary loops. So those are the lymphocytes and neutrophils. Most of the time, the first cells we see are the neutrophils. The lymphocytes are not very prominent in early antibody-mediated rejection. So if we start seeing some neutrophils in the glomerular capillary loops, as well as along the peritubular capillaries, and as you said, rolling means like margination of those neutrophils, then we suspect that there is something going on with this biopsy in relation to AMR. Do we have a next picture, Irfan Bhai? Yeah, so this is another very good picture. You can see how the peritubular capillaries are dilated, and yeah, and there are lymphocytes in the lumen. I don't personally classify the degree of number of lymphocytes in the pericapillary tubes, like 4 is mild, more than 4 is moderate, and then severe, because nobody cares. But you can see that the C picture has more inflammatory cells right there. So this has a more severe antibody-mediated rejection as compared to A, which has only 4 or 5 lymphocytes. So this is a very first, histologically, you would see these changes, ATN and peritubular capillary dilatation with neutrophils. At the same time, we do C4D on all our transplant biopsies because we don't want to miss antibody-mediated rejection. So this is an example of C4D stain, as Irfan Bhai just mentioned, that because of the C4D molecule, it has a positive, this is IHC staining. You can see the brown staining along the capillaries. And then on your right side, it has IF staining. All these are peritubular capillaries that are brightly green, apple green appearance. It has a linear positivity. There is no granular positivity. And when we see it, we call it antibody-mediated rejection, but it has to be clinically correlated with the patient's symptoms and antibody levels. I only tell them your C4D is positive, and I only report in my report that immunohistologically, antibody-mediated rejection, clinically correlation is required, because just positive C4D cannot make it antibody mediated rejection. Okay, so next slide, Irfan bhai. Yeah, so this is an example of endothelial arthritis. The first picture has, yeah, right there you can see subendothelial lymphocytes. When you start seeing subendothelial lymphocytes, that's a first indication that this patient is having endothelial arthritis. And then there are very few lymphocytes in the first picture, but the B has more advanced lesion. It has more lymphocytes. And then the C, if you look at the C towards the very lower end, where you see the, yeah, right there, it's a fibrinoid necrosis of this wall. So this has become a V3 lesion when you started seeing more advanced fibrinoid necrosis. So V1, V2, V3, and then the last one is showing interstitial hemorrhage. Sometimes this is a very helpful feature for us to suspect that there is an involvement of medium-sized blood vessels, because sometimes the biopsies are small and the sample is an issue. If I don't see big blood vessels in my biopsy, which is very unlikely to see medium size or larger size blood vessels. So if I just see the interstitial hemorrhage, it simply means there is a vascular involvement. And I tell my clinicians that you have to make sure that this patient has a vascular involvement, like a more severe rejection. So treat them aggressively if I see the hemorrhage. The hemorrhage is an indication of vascular involvement in antibody-mediated rejection. And the key is, the early you treat these patients, the chances of going back to normal is much higher. So once you start seeing the fibrinoid necrosis or severe interstitial hemorrhage, these kidneys usually have not a very good prognosis. This is another form of antibody-mediated rejection where you see acute thrombotic microangiopathy. All these dark red, pink color are fibrin thrombi right there. Yeah, so these fibrin thrombi basically form because of the endothelial cell injury. As Dr. Agha said, once they have endothelial injury, they start forming these fibrin thrombi and they look like thrombotic microangiopathy. The right side of this picture is a medium-sized artery. You can see the fibrin in the wall of this artery also. So that's another feature that we have to look. It's a trichrome stain. That's why it looks more blue background and pink fibrin material in the wall of this blood vessel. One more thing I want to mention, sometimes calcineurin inhibitors can also give you TMA. So you have to be careful to differentiate the cause of the TMA on transplant. So you have to have C4D positivity and DSA antibodies in correlation with TMA to call it antibody-mediated rejection. Next line, Irfan bhai.
All right, so yeah, I'll pick it up from here. Thank you, Shanila. So this is then the edifice on which the diagnosis of antibody-mediated rejection was created. There were three different things, and this is how we started the journey. This has changed quite a bit, and we'll kind of go over why. So the three things that we used to look at was the presence of donor-specific antibody, donor-specific antibody and endothelium interaction, which is C4D, and then tissue injury patterns, which Dr. Latif has just gone over. So these were the criteria based on which the first diagnostic criteria for AMR were promulgated. This was in the Banff 2003 edition. Morphologic evidence, you've got the PTCitis, glomerulitis, fibrinoid necrosis, TMA, and ATN. So this is the morphologic spectrum of the disease. And the ATN is, it's kind of intuitive to understand why that happens. We talked about all those peritubular capillaries, which are inflamed. If you kind of visualize that, that's the peritubular capillary network that is supplying the loop of Henle and the tubule. So once you've got inflammation over there, you're going to have ischemia to the tubules, and that may lead to ATN. Now, immunohistologic evidence, diffuse C4D capillary and arterial necrosis, serologic evidence of circulating DNA. So DSA, endothelium DSA interaction and tissue injury pattern. But the Paris group with Alex Lupi looked at their data applying the Banff 2003 classification, and they found three groups of people. There was a group of people who had no C4D staining and had no microvascular injury. So glomerulitis and PTCitis together are called microvascular injury. So no microvascular injury, no C4D. Then there was a group which had C4D and microvascular injury, and a group that had microvascular injury and no C4D. So based on the 2003 criteria, this group fell off. This group was no longer considered ABMR because they didn't have C4D. But what they looked at, when they looked at the outcomes, what they found was that this group, which had no C4D but had microvascular injury, behaved more like people with AMR than they did with patients, people without AMR. So let's take a look. Their C4D was negative, this group. The C4D was positive in the antibody mediated rejection group. Now the GFR at 3 months for the people who had AMR was about 49, was about 56 for the people who didn't have C4D, and was about 60 for the people who had no evidence of either C4D or microvascular injury. So that's at 3 months, but at 12 months, the GFR for both these groups has dropped. So the GFR at 1 year for the antibody-mediated rejection group is 40. The GFR at 1 year for the C4D negative microvascular injury positive group is 46. But the GFR for the group with no microvascular injury and no C4D is preserved at 62. So that's when we started realizing that there's more to rejection than C4D, and it depends on the antibody subclass, the degree of glycosylation. So when we look at our usual cartoon for antibody, we look at the heavy chains and light chains. Actually, the antibody molecule is much more complicated than that, and there's a lot of ornaments that hang at the hinge region and all with various types of stuff on it, which actually changes the way the antibody behaves. So their glycosylation patterns, the density of the antigen on the target area, and the concentration of the HLA molecules, all of that leads to varying degrees and varying types of reaction. So you can then have a very, very large spectrum. And the effector mechanisms are very different. So if you've got a very heavy C1q binding complement activating antibody, that would cause predominant damage through C4D. If you have antibodies that don't do any of this stuff, don't do any inflammatory stuff, they will actually lead to phenotypic change and eventually clinical change based on endothelial cell damage. And then there are patterns of chronic inflammation that happen in antibodies that don't recruit complement but recruit other inflammatory cells. So this is what has led to certain refinements of our criteria. We have figured out what microvascular injury is and what its importance is. We've figured out that DSA is important with C4D, but there could be other molecular markers that can be important as well. And then we look at endothelial interactions, and molecular transcripts have come in a big way to kind of help us understand that even if your C4D is negative, could your endothelium or the biopsy be suffering from antibody-mediated damage? So when we let some of this fester, so some of these are going to be very fast. So our first case that we talked about went into acute kidney function like there was acute kidney injury like there was no tomorrow. But the last patient was very, very stable. You know, they were just sitting around. The creatinine was stable. The proteinuria was not too bad. So there's a whole spectrum of this, right? So there are people who've got antibody-mediated rejection, which is subclinical, which is just sitting there slowly nibbling on the graft. And it is those people that can run into, if we don't treat this effectively, those people will run into chronic injury patterns. So I'll invite Dr. Latif back to talk a little bit about these chronic injury patterns now.
So in chronic transplant allograft rejection, what we start seeing first is like duplication of the basement membranes. The peritubular capillaries, because of the chronic injury, they started reacting and then they started layering the basement membranes. So the first picture, the arrow is showing right there multiple layers of the basement membranes. It's, if I have to count, it's more than 7 and 8 layers. And as similar to the right side of this picture, this is a small capillary. You can see one endothelial cell and a lumen. And then right there. And then the basement membranes where the arrow is pointing, it's multiple layering. So this, whenever I see this changes on EM, that's an indication of ongoing chronic rejection. And most of the time there will be another, right there. So this is another good example of transplant glomerulopathy. In transplant glomerulopathy, exactly same phenomenon due to chronic ongoing rejection. There is a reaction of endothelial cells and they start depositing some acellular material underneath the basement membrane. Yes, right there. It's called subendothelial acellular material, which gives basically a thickening of the basement membrane. So they look very thickened on EM, and then on the silver stain in slide B, you can see the basement membranes are duplicated, and they look like basically MPGN. Overall, the glomeruli gives you a MPGN pattern with duplicated basement membranes. The D is the best picture. All the arrows are pointing towards the duplication, or we call it tram track appearance of the basement membranes. When, exactly right there where Fanbhai is pointing, and the top arrow, the first arrow on your D, right there. So it's silver stain. It's very good for basically looking at the basement membranes, and if they are duplicated, they are thickened, you have to suspect ongoing antibody mediated rejection. And at this point, these patients start having proteinuria, and the clinicians start getting worried. This is another picture where you can see some mild mesangial expansion and increased cellularity, like a mesangial lesion there. And then the right side is the arterioles that are thickened, hyalinized, and kind of onion skinning. The right picture right there has this onion skinning appearance, which is called vasculopathy or arteriopathy. You can say transplant arteriopathy. This is another very good pictures. You can see there's a trichrome stain, the right-hand side, this picture. So what happened is, due to chronic ongoing antibody mediated rejection, we call this lesion as onion skinning. And why we call onion skinning? Because there is a fibroplasia here. Underneath the intima, all these fibroblastic proliferation appears, and then the lumen of these arteries are very pinpoint, narrow lumen because of the fibroplasia. And sometimes you can see the foam cells or histiocytes. That's Dr. Agha just mentioned that because of this injury, the CD68 positive histiocytes start rolling in the lumen of these blood vessels, and you start seeing these histiocytes. So when you see foam cells or histiocytes in the blood vessels, when you see fibroplasia, it simply means this kidney is gone, like kaput. This is irreversible, and you need another transplant. So I guess that's it.
All right. So let's see if we can save our patients from getting into the kaput stage. So these are the various avenues through which we treat antibody mediated rejection, technologies to remove antibody, PLEX, IVIG, immunoadsorption, IDs, which is one of the neuroenzymes that has come out. Then you target the source of the antibody. So these are only going to take away, apart from IVIG, these are only going to take away antibody that's actually circulating. That you have to target the antibodies and the cells that are actually producing the antibody. So in that circumstance, you want to use the steroids, CD20 antibody, proteasome inhibitors, IL-6 blockers, thymoglobulin, Campat, depending on what's going on. And then the endothelial protection mechanisms, which are through eculizumab, which is a C5 blocker, and then IL-6 blocker. So we will quickly go over that, over some of the modalities, and then we'll go back to our cases and see how we did with them. So plasma exchange and low-dose IVIG is probably the only type of therapy that has got some data. Most of this is really a data-free zone. Not very good data for any of those modalities is available because this is a very complex and heterogeneous population. As I mentioned, the 4 cases are all antibody-mediated rejection, but they are perhaps 4 different diseases. So the standard initial regimen for any antibody-mediated rejection is plasmapheresis and IVIG. Usually we do 1 to 1.5 plasma volumes for 3 to 5 sessions. IVIG is returned at 100 or 200 mg per kg or 100 or 150 mg per kg per session. So after the plasmapheresis session, we usually combine these with other modalities of treatment based on what's going on. High-dose IVIG alone is something that Cedars-Sinai has made it their own. So they have 2 different protocols. One is for regular antibody-mediated rejection, where they give steroid pulses, give a high dose of IVIG, so 2 grams per kilogram. So contradistinction, where here we're giving 100 mg per kg per session. There they give a jumbo dose of 2 grams per kilogram. And then 2 days later, they give a dose of rituximab. And then about 30 to 60 days out, they give another dose of IVIG, same 2 grams per kilogram. And they've had pretty good results with this. In patients who have got the really bad, aggressive acute renal failure, so the first patient that I presented who went from 0 to 60 in like 2 days, this is what they would do. They would plasmapherese, then give 2 grams per kilogram of IVIG and rituximab, and then follow it up with another dose of IVIG. So this is pretty much something that Cedars has done quite a bit. I use this sometimes when I'm trying to walk the tightrope where there's an infection and I have to deal with antibody-mediated rejection. And I've done this several times, especially when I'm dealing with something like BK or something like that. So it helps me walk that line where I'm not really making the BK flare up. Imlifidase or IDase is a streptococcal enzyme. Essentially what this does is it breaks open the antibody molecule, takes away the variable region from the constant heavy domains at the hinge region. So this is an MFI readout of antibodies. So the red bars, which look like Manhattan, are the antibody levels before treatment. You give them imlifidase, and look at the blue bars. This is where they go down. So they turn from Manhattan to Macallan very quickly. And this is, again, C1q binding antibodies. You have these very high levels of C1q antibodies. You treat them with imlifidase, and you can't even register the antibodies an hour later. This cannot be redosed. It can be given only once because you do develop neutralizing antibodies against the enzyme very quickly. And so this is something that can be used in a very severe storm of acute antibody-mediated rejection, or when you're trying to desensitize somebody, but this does nothing to the antibody-producing cells. So the bucket will fill up very quickly if we don't take care of the backfill. Targeting antibody-producing cells. We target CD20, rituximab, which takes care of most of our B cells, memory B cells, and early plasmablast populations. We use bortezomib for plasma cells, CD38 and daratumumab antibody, anti-CD38 antibody is now being used as well. That takes care of just the plasma cell, does not affect B cells or early plasmablasts. So as the plasmablasts, as the memory B cells are turning into plasmablasts, what they're doing is they're losing their CD20, then they lose their CD19, and then they convert into, they gain CD38 and sometimes 138. So sometime during this process, the plasmablasts will lose CD19 and 20, gain CD38 and 138. And so at that point, they will become refractory to rituximab, but will become susceptible to daratumumab or now, complement is again imlifidase. It's an umbrella you pull up. So this was a study that was done out of Mayo several years ago. Yeah, almost 10 years ago. So what they did was they picked up 26 patients with baseline B-cell flow cross matches between 450 and 200, so positive, but not really, really positive. And they gave them eculizumab, and they compared them to 41 historic controls. And what they found at the end of the study was that, yes, they decreased acute antibody-mediated rejection in this very, very high-risk group, right? These are guys who've got positive B-cell cross-matches. And so they dropped the antibody-mediated rejection rates, early antibody-mediated rejection rates, from 41% in the controls to 7% in the study population. So huge. But when they looked for long-term outcomes, the follow-up study on the same patient group, again out of the Mayo, published by the Mayo group, they found that there was no difference in the transplant glomerulopathy incidence in these patients. So again, what is happening here is you've opened up an umbrella, but you've not stopped the rain. So once at 6 months or 9 months, you fold the umbrella, it starts raining again and you get into trouble. So the idea behind these strategies of endothelial protection or imlifidase is that you gain temporary respite by decreasing the amount of antibody in circulation or protecting the endothelium from the antibody in circulation, but then you have to do something to decrease the antibody production itself. IL-6 is one of the newer kids on the block. It is a very, very strong cytokine released by plasmablasts as well as endothelial cells after they get injured. And so when it's released by the plasmablast, it works locally and moves this process along where your B cells are going to turn into plasma cells. But more importantly, when IL-6 is, when HLA antibody toggles the endothelium and the endothelium releases IL-6, it actually traffics by producing IL-21. So IL-6 and IL-21 are very strong stimuli to move these naive T cells to play the BCL6 program. And when they play the BCL6 program, they turn into T follicular health cells. We remember where these guys work. These work in the lymph nodes and help the B cells in launching an immune response. So this is how everything comes together. And there's a lot of talk of using IL-6 blockers in these patients with chronic antibody-mediated rejection. So we'll come back to some of this in a little bit. So we now return to our first case, which is Poseidon's Thunderbolt, the guy who was fine and about to go home, but then developed a massive acute antibody-mediated rejection. And I don't think if Dr. Latif remembers, she actually read this biopsy and she said, this kidney is kaput. But what we did with her, so this is what happened with this biopsy, that this guy had, I'm sorry, not the biopsy, this patient, that this guy had memory B cells, had kind of lost significant antibody from the plasma cell side, but had memory B cells in the system. And when he was exposed to the A52 antigen, the memory B cells revved up, sheets of plasma cells were produced, a huge amount of antibody was released, went in, fixed complement, destroyed the kidney. So this patient had severe TMA. It looked like a bomb had gone off in the kidney. We treated him with steroids, plasma exchange, and IVIG, and we treated him with bortezomib. And this was in 2011 or 2012, something like that. And now the guy still has a creatinine of 1.4 and no proteinuria, did not develop chronic antibody-mediated rejection because this was class 1. Usually you do develop chronic antibody-mediated rejection if you've got class 2 antibodies. So this was a success, and we did a biopsy in him 3 or 4 weeks later, and the kidney looked normal. It's just fantastic how the kidney goes from completely destroyed to normal within a few weeks, and the endothelium is able to heal itself. This is our Aphrodite, who had a fight with her, or keeps on having fights with her significant other. And so she, like I mentioned, was transplanted in December of 17, was non-compliant, had a cellular rejection in 2018, got another dose of thymoglobulin, and then in June of 2019 was admitted with rejection again. So this time her rejection was read as an I2 T3, so significant interstitial inflammation and tubulitis. So there's a T cell component to it. She did not have any arteritis. She did not have any hyalinosis. She had a G1, PTC1. So still the predominant flavor of her rejection is cellular. She was treated with a steroid pulse, was given plasmapheresis and IVIG because she did have C4D and microvascular injury now. So she was treated as a combination of AMR and ACR. And then she went home and unfortunately lost insurance and became non-compliant again, came back in October of 2020. And at this point, she was treated with, she was biopsied and had an I1 T1, so a little bit of tubulitis, not as much as she had this time, but now she has very severe microvascular injury. So her G2, PTC3, and C4D staining is 2+. So she's now graduating from mostly cellular rejection with some antibody-mediated rejection to now predominantly antibody-mediated rejection. So this is a young woman. We've treated her 3 or 4 times, and now we're stuck again with this situation. So what do you do? And so this is where she's been at. So this is a classic example of indirect LO recognition. She's had CMR alone. Now she's had AMR and CMR combination, and sometimes, rarely, these guys get a pure AMR as well. So I'll come back to how we are planning to treat her in a second. So this is the third guy who we thought was a closet alcoholic. In July of 2017, he received induction with basiliximab. So I fixed it on this slide and not on the first. He had stable proteinuria of about 500 milligram per gram. Proteinuria, like I mentioned, increased to 2 to 3 grams per gram. Cell-free signature was high. He had a new class 2 antibody. He was biopsied, very severe microvascular injury, not a lot of chronic change. So he was given a steroid pulse, was plasmapheresed, and was given a dose of rituximab. In June of 2020, he was rebiopsied. He had acute antibody-mediated rejection again, but he had EM findings of early TG now, not good. And still does not have a lot of interstitial fibrosis or tubular atrophy. So what do we do next? So this is the toughest part of treating antibody-mediated rejection. The early AMR phenotypes are the most cataclysmic, come in with very severe, rapidly progressive acute kidney injury, but they are also the ones that actually respond to treatment better than their late counterparts. The late counterparts don't do well, and everything has failed. Everything that we have tried in patients with this late antibody-mediated rejection, especially when some chronicity like PTCL multilayering or TG sets in, they don't respond well. And we keep throwing things at them. And the reason they don't respond well is because the pathogenesis of the immune response is different in these cases than it is in the early phenotypes. In the early phenotypes, there's memory B cells, and if you can get on top of them quickly and kill the plasma cells that are chugging antibody and deplete the memory B cell reservoir, you can get on top of it. In chronic cases, you get into trouble because there's constant recruitment of the immune system. And what it turns out is that as we deplete these people, there is almost a proliferation in the secondary lymphoid organs. B cells and T cells talk, and they generate constantly more memory B cells and plasma cells. So no matter what you do, this is why Borteject failed. Bortezomib was an ideal situation for these chronic antibody-mediated rejection patients, but the trial failed because what was happening was your antibodies go down for a little bit, but they come right back. And why they're coming right back is because of this ongoing immune activation in the secondary lymphoid organs. So now there's a move to use belatacept in these patients. So there's several case series that are coming out where you use bortezomib to deplete them, but then put them on belatacept to disrupt this communication between T follicular help cells, the BCL6 transcribing T cells that are egged on by interleukin 6, and between B cells that are looking for cognate help from these follicular help cells in the lymph node to disrupt generation of this. And this is the proof. This is a non-human primate study. So this is not a human study, but what they did was they treated these patients with bortezomib, these subjects with bortezomib and belatacept, and they found that the helper T cell population after treatment, as well as bone marrow plasma cell population after treatment, dropped significantly when they used this combination. So coming back to our gentleman who we treated for acute antibody-mediated rejection, but now is developing some transplant glomerulopathy. We subjected him to another cycle of plasmapheresis. We subjected him to bortezomib. We switched him to belatacept, Envarsus, and steroids to improve his compliance. So he's taking medicines once a day. He's getting belatacept once a month, and we also gave him tocilizumab, which is an IL-6 blocker. So his proteinuria is steady at 2 grams per gram. His DSA, which was more than, it was a DQ2 antibody, which was more than 20,000, is now in the 4,000 range. His allosure was, allosure is cell-free DNA, was in the donor-derived cell-free DNA, which was in the 7% range, dropped to 0.4% after treatment, but now has crept back up to about 4%. That's not good. That's worrisome. So we are going to likely rebiopsy him and see if other avenues of intensification are possible, or whether we continue with this and keep giving him tocilizumab for a longer period of time. This is also what we have done for Aphrodite. We have given her another cycle of plasmapheresis. We've given her bortezomib, and she's been switched to belatacept. She's on Prograf and steroids. So both of these are high-risk cases, so we're using belatacept with a calcineurin inhibitor. Finally, Athena's wisdom. And again, Athena here is my partner who picked this up. This was a patient, young female in the 30s, living unrelated kidney transplant in March of 2018, induced with Campath. She was seen for a routine outpatient visit. Her creatinine was 1.1, so not too bad. 700 milligrams per gram of protein, previously had been about 400 to 500. DSA was negative, BK, PCR, and CMV was negative. Truly, if I were seeing her just for a visit, I would say you look okay, and I maybe slap her on some ACE or ARB and send her home. But her surveillance cell-free DNA was very high, which is suggestive of some ongoing injury to the allograft. So based on this, we biopsied her, and it displays the changes of microvascular injury that Dr. Latif so elegantly went over. So this is these are taken by my cell phone over the microscope, so not very good pictures. But if you really pay attention a little bit, you can see these lymphocytes in the capillary. So you're looking at glomerulitis here, but you can see these peritubular capillaries are chock full of inflammatory cells. So clear, significant microvascular injury, and C4D was positive in about 25% of the PTCs. And like I said, our donor-specific antibody was completely negative. So what do you do in this situation? So we checked for non-HLA antibodies, and her angiotensin 1 receptor antibody was very high, more than 40, above their level of detection. We treated her with steroids, plasmapheresis, and IVIG. She did receive a dose of rituximab. Now, during this treatment, she developed catheter-related bloodstream infection, but otherwise tolerated the procedure quite well. So what was her course? Actually, her cell-free DNA, which was high at 5.4, fell back below to 1%. And her creatinine went to 0.8 to 0.9. Proteinuria went below 500 milligram per gram. But then her cell-free DNA a couple of months later jumped back up to 2.5%. We biopsied her, and surprise of all surprises, this current biopsy demonstrated an immune complex mediated GN with mesangial, subendothelial, and rare subepithelial deposits. Her immunofluorescence microscopy showed staining for C3 and IgA. Light microscopy shows mesangial and endocapillary hypercellularity. So I'll have a cookie for whoever can tell me why this happened. This was not recurrent disease, which is what the pathologist thought, and that pathologist was to force to go something with the diagnosis. This was not related to her antibody-mediated rejection. So her current status is that her antibody and angiotensin-1 receptor antibody is low at 12. Her proteinuria is actually settled to 200 milligram per gram, and her last creatinine I looked up last night was 0.9 milligrams per deciliter. Her cell-free DNA signature is steady in the low 2% range. So we might still have some ongoing microvascular injury, and we'll probably biopsy her after a discrete interval and continue to follow her cell-free DNA signature. So these are the different complexities of antibody-mediated rejection, and it's a very, very pleomorphic entity. So each patient needs to be evaluated based on their specific characteristics so that we can come to a well thought out treatment regime. So these are not the type of patients where you can protocolize things. Every patient is unique, and you have to think through every patient's data and clinical course before you can ask them to follow one or the other course of treatment. So I will stop here, and I'm happy to take any questions that may have come up.
Looks like there's a question from Dr. Kiyon.
Is it on chat?
There's one on chat.
Okay, hang on. Let me just stop sharing my screen so I can read the chat more effectively. Okay, on some occasions, we have no other option but to do a blood transfusion post-op, considering most patients receive a 3 to 5 mg per kg of thymo as induction. How big of a risk are these blood transfusions in terms of AMR risk? Is there a case of doing DSAs, let's say 2 weeks of blood transfusion? Okay, yeah, I think the risk of a blood transfusion provoking an anamnestic response is very little. So I wouldn't worry about that. I think what I would want to do is to just follow the clinical course after that. Now, if your patient is high risk due to other reasons, they had pre-existing antibody, then that needs to be followed on its own merit. But if you run into a situation where you're transfusing somebody, I wouldn't really worry too much that is going to lead to, because these are packed RBCs and the HLA exposure is not horribly high. And I think the body can deal with that, especially with significant immunosuppression. Now, there's another question, which is how to differentiate between chronic ABMR from recurrent MPGN. Now, that's a very, very good question. So I would venture to answer that by saying that MPGN is not a disease. MPGN is a pathological lesion, just as FSGS is not a disease, it's a pathological lesion. So actually, chronic transplant glomerulopathy is an MPGN pattern. I mean, what we described, that there's some mesangial expansion, there's some inflammation, and there's duplication of the basement membrane, that's TG. Now, TG can be driven by many different things. It can be driven by immune complex related processes. So we can see that in lupus. You can see that in IgA-driven processes. You can see that in complement-mediated disease, so with C3GNs and so on and so forth. And sometimes you can see a transplant glomerulopathy process which is completely dark on immunofluorescence. So no immunoglobulin, no C3, in which case it kind of looks like a TMA. So the thing is that this is a TG lesion. It's just that it's derived by alloimmune antibodies, not autoimmune antibodies. I hope that answers your question.
Plus, I think the recurrent pattern of GNs, it all depends what was the original or de novo disease. I mean, if there was some sort of a dense deposit disease or some other known pattern, then if it comes back, then it's going to be more likely to be that original disease rather than driven by the MR.
Very true. Very true.
So
any takers on the last case on why that patient had immune complex, an immune complex driven GN on the second biopsy after having been treated for AMR? So let me review again what the biopsy showed. It showed an immune complex mediated GN with mesangial, subendothelial, and rare subepithelial deposits. Immunofluorescence microscopy showed staining for C3 and IgA, and there was mesangial and endocapillary hypercellularity. So the conversation I had with my, any takers, anyone venturing a guess?
Can I say a few words?
Yes,
if I
please.
So the way you are describing me, I'm on EM, I'm believing that there are true deposits, like true mesangial, subendothelial, subepithelial deposits, right?
That's true.
And we know that the patient didn't have IgA to start with, like her primary disease was not IgA nephropathy.
Her primary disease was lupus, actually.
Yes, so this is recurrent lupus because of immunosuppressant. These patients usually don't present with full house on IF. So IF is misleading with these patients. You have to make sure that you know the history and you correlate with the deposits, locations, and everything. So this is recurrent lupus. Sometimes it's very difficult to diagnose, but I would call it recurrent lupus if she has a primary lupus nephropathy.
Now, that's exactly what my pathologist said. And I was scratching my head and saying, we just freeze the bejesus out of this patient. Why would she develop lupus now, right? We just treated her with very, very strong immunosuppression. So essentially, there was a little piece of that. I had put that in that tidbit in my presentation that she had developed a catheter-related bloodstream infection. She had Staphylococcus bacteremia. So this actually, and so the conversation I had with my pathologist was, please go back, look at the EM and see if you can find me some subepithelial humps. And she went back and looked at the EMs and said, yes, there are subepithelial humps there.
Yeah,
So
post-infectious GN can also give you IgA deposits. That's 100% true.
This was an IgA dominant post-staphylococcal infectious GN. So that was a very rare case. And it gave us a lot of anxiety for a few days, like, how rare, how unfortunate could this patient be that we just ended up treating her for an AMR and now she's got recurrent lupus. But turns out it was something that we had given it to her. Well, she had developed a catheter-related bloodstream infection, which was Staphylococcus aureus. I didn't give you that, otherwise it would make it very easy. And so this was a IgA dominant post-infectious GN. She's actually fine, and her proteinuria remains pretty low. She was probably in the process of cleaning this up because this was about 2 months after her infection. And this also tells you that, if you biopsy a lot of these patients, you will find some of these. Not that it changes management that much, but just from a diagnostic standpoint. So, where Umar is or Avas is, where fellows are learning, these are good cases to biopsy from time to time when you see these hematuria and proteinuria type deals after infections and so on and so forth.
No, I think this is the classic dilemma between the infection and rejection. And then, so you saw basically both. The infection is going to be self-limited, but it gave you more anxiety.
There you go.
Right? Yeah.
Exactly right. So there's a question coming in from Ahad, which says ATG Fresenius is relatively cheaper in Pakistan I understand we have to increase the dose if we use Graflon, which I think is ATG Fresenius's trade name. Any experience of using Graflon in place of Thymo? Which one do you use? I use Thymo. I've never used ATG, but from reading the literature and the various studies, and most of this has been done, there are a few studies of ATG and Thymo and ATG Fresenius in kidney transplant. But most of the literature is driven by the bone marrow transplant people, where they use this as induction to avoid graft versus host disease. Now, the usual regimen they use with ATG Fresenius in transplantation is 9 mg per kg initial dose and 3 mg per kg on day 3 or so. So that's 12 mg per kg total. And reading the literature, I think you have to multiply the Thymo dose by about a factor of 1.5 to 2 to get the requisite ATG Fresenius dose. But I have no direct experience of using ATG Fresenius. I've never used it. I've always used Thymo, and that has not been an issue for me. Anyone else in the audience?
Yes, Irfan, we are using Fresenius ATG all because of the cost things. And we have used in about 110 patients, except the haploidentical, as you know, that's a slightly heavy program on ATG. And the multiplication I use is a 2. So if you want to give any patient 4 milligram per kg, you need to give 8 milligram per kg of this Fresenius ATG. And we are using doubling the dose of 1.5 milligram per kg of Thymo, the Sanofi one, just doubling the dose. That's the way we are carrying it. And it's very good. And almost we have only 1 case of AMR, but in Pakistan, it's all a living donor transplant. And if we can fix our HLA labs, I don't think we will have that much of a problem regarding AMR as you people have.
Yeah, so I mean, AMR is not very common. It's exciting, but it's not very common. I'd much rather treat diabetes and hypertension after transplant effectively to increase these patients' lives than, keep treating AMRs. But when you treat it, it's kind of interesting, and it gives us a lot of insight into what's going on in those graphs. But our AMR rates are less than 5%. Acute AMR rates are less than 5%. But what's killing us is the chronic antibody mediated rates. And actually, you don't know your rates on those either, because you're not even tracking those. So that's the issue. So, the thing is, the acute antibody mediated rejection is easy to treat. Well, not easy to treat, but it responds to treatment. Like I said, chronic antibody mediated rejection is a very, very difficult thing to treat. We really don't know how to do it. Now, the patients that we are now switching to belatacept and trying to use tocilizumab and all that, time will tell if this is a good strategy or not, whether we eat too much infection trying to treat this or not. So we'll have to educate ourselves as we go along.
So if you allow me to comment on something, I think how we understood the AMR and how we have been treating in the last decade or two, I think it has evolved drastically. Even within the United States, I can tell you that what you just described is kind of way ahead of the curve. Some of the centers are catching up. Most of this, like I know my center, so we have this protocol, AMR. So first, the diagnosis was always a question. How many criteria, and finally, now people have better hold of the diagnostic criteria and diagnosis. And I think it's better collaboration between nephrologists, pathologists, as well as the HLA team. So now we are getting, more better versions of the diagnosis. Okay, this is the diagnosis, you go ahead. Once the diagnosis is made, I think it's pretty standard: pheresis, IVIG, rituximab. Some patients, folks are going to bortezomib, but very, very rarely. So it's pretty straightforward, the protocol, and then you just recheck, and then you bring on another protocol. So the question, the point is that how you are treating your patients, your center is ahead of the curve. I have to tell. Now, question back to my colleagues from Pakistan is, how are you handling all this? I mean, because I think this is again, as I mentioned, that what Dr. Agha is treating at his center is quite advanced than what I'm treating at my center is. So how are you handling this in your place? And what are the gaps if you feel that needs to be filled?
Right. Omar, we had one case of AMR, and I think, Irfan, it was more like an anamnestic response, the type 1 AMR you described. And I'll tell you the true story. The patient comes to the clinic after discharge on day 7. We discharge the patients on day 5. He comes with a creatinine of 1.6, something from 0.9. We admit the patient. Patient goes from oliguria to anuria. We biopsy the patient. I send the single antigen bead tests. We biopsy patient, all workup, TMA, all we are all crazy. The biopsy is sent to Shaukat Khanam. The report comes the evening. Report is it's Banff 2 T-cell mediated rejections. Thymo is initiated with my plan because he was already receiving 4 milligram. Plan was to give him another 5 milligram of Thymo. And then I receive a call from the HLA lab that DSAF to DQ antibody is 7,500. Then I call the histopathologist there and I said that in the meantime, the patient's urine output started. Patient started to improve with Thymo and steroids. And then I give a call to the Shaukat Khanam people that the one antibody to DQ is coming about 8,000 MFI. And we are doing serial dilutions also. It's diminishing, but not diminishing to that. Can you just give me a comment on the C4D staining and the PTC and G lesion? He said, Adil, can you just come to the hospital tomorrow morning? It was a lucky Saturday, so I went and I found out that the PTC was about 2 and there was some G lesion also. He said there was no C4D. And C4D in Pakistan is doing by immunohistochemistry. So what we did that day, in this meantime, the serum creatinine was coming down. Thymo was ongoing. We did freeze him and we gave him 1 dose of rituximab also. And luckily the patient recovered. He's now doing well with me. His creatinine is 0.6. So he received Thymo, he received Plex 5 session, and he did receive a 1 dose of rituximab. Sorry, one thing, I mean, I gave him 2 grams of IVIG at the end of plasmapheresis sessions. So this was only our case in which we suffered. My only one comment, Irfan, which I might, you will differ with me in this point, that the AMR is usually not a pure AMR. It is usually associated with some T-cell mediated rejection because the same concept, the T follicular cells will be required for the B cells to differentiate into the plasma cells and the whatever short-lived and long-lived one. So the initial, 6 to 7 years before, what we were practicing in this AMR, just giving Plex IVIG, rituximab, or Plex IVIG or Velcade, which I was practicing. I think that T-cell lymphocyte depleting therapies with the new concept and the pathogenesis and biology of AMR is evolving, and ATG definitely has a role other than the cellular infiltration which accompanies the AMR.
So I think we just have to be very careful in really being careful in what we are calling what. So let me just quickly go over this again. So when we have pre-existing antibody, right? If you've already got a pre-existing antibody, what this antibody is telling you is that there's plasma cells in the bone marrow niche which are making this antibody at a stable rate. And by corollary, you also know that there's memory B cells there, right? So in this circumstance, when the antigen is seen again, memory B cells are able to see that antigen directly. There is no follicular reaction. There is no germinal center proliferation. So a pre-existing antibody, especially when it happens early, it is usually a pure active AMR or active or chronic active AMR. These are usually more on the purer antibody-mediated rejection sites. However, when you have de novo antibody generation, which means you're now having the classic canonical antigen presentation through your antigen presenting cell to the T helper cell, and then the T helper cell generating an immune response, antigen presenting cell also talking to the B cells in the lymph nodes, and then those B cells getting cognate interaction with follicular help cells. That is more likely to being a mixed cellular and antibody-mediated rejection. So these are the phenotypes of antibody-mediated rejection, where you have coexistent T-cell mediated rejection, which is common. But when you're having a reaction to a pre-existing antibody or a rejection due to pre-existing antibody, you don't need T-cell, B-cell interaction in that. You've already got plasma cells. Plasma cells see the antigen and turn into plasmablasts and memory B cells see the antigen and turn into plasmablasts and plasma cells and lay out sheets of antibody within days. So that's a different animal compared to this. And this is why it's important to understand the phenotypic difference between and the pathophysiological difference between the two types of rejection. So I'm 100% with you that when it's de novo antibody generation or late ABMRs, you almost always will have coexistent T-cell mediated rejection. But when you have a rejection due to pre-existing antibody, that is more likely to be a pure antibody-mediated rejection. Is that something you agree with?
Yeah, that's fine. That's the anamnestic response in which the memory cell just gets stimulated.
That's right. That's your anamnestic response.
The interpretation of this lesion, my question is that PTC is the only lesion which is specific for AMR is a C4D, and now it is also by the Banff that there is a C4D negative AMR.
Yeah.
The PTC lesion can happen with the T-cell mediated rejection also. Sure. Okay, yeah. Glomerulitis can be a part of the recurrent diseases, glomerular diseases also.
Sure.
The question is that in a C4D negative AMR, okay, if you know DSS, there can be asymptomatic DSS and there can be a symptomatic DSS, depending upon which is stimulating the C1q and IG3 subclasses and the two pathways which you have very well defined, the AKT pathway and the complement pathway. In that case, the things can become slightly confusing at that point.
Yeah, so let me kind of take them step by step. So microvascular injury, which is glomerulitis with PTCitis, you can see in T-cell rejection, severe T-cell rejection, but in those cases, you will see severe tubulitis. So it is not that you will have an isolated PTCitis or glomerulitis and not much by way of T-cell rejection. So in those cases, when you see this, you are going to interpret that in the context of a severe T-cell mediated rejection. When you see glomerulitis with a recurrent disease, you don't see that much of PTCitis and there's nothing else going on. So these are syndromes you have to pick up and look at them. This is where your clinical judgment comes in. You look at all the different ingredients that are in front of you and then try to decide what is it that you're dealing with. And usually I find that once you've looked at it, and part of this is your support structures, because if you don't have good DSA reporting available, if you don't have good histopathology support, you know, when I was in San Antonio, every morning after rounds, we would go to Dr. Latif's office and, you know, look at biopsies, and whatever she said was law. You know, that's what it is. We agree with that because she's very good, and Dr. Banyan before her. So it depends on who's providing you with the data. But once you've got the data ingredients out there, it is relatively easy now that we understand these different phenotypes, different syndromes better to pigeonhole them correctly. But you're right. I mean, this is not easy. This is why you're in such high demand.
And I think we, again, the first type, the first rejection phenotype, which is the pre-existing antibody, we see very rarely. I'm just trying hard to recall if I have seen it, and I don't. I think the second version, and especially towards the, several years out, is what we are seeing. And I think the cases are similar, the fight with the significant other and then drop in antibody, the immunosuppression and some multiple other factors. So the first phenotype, I don't think we are seeing that much, but the second we are seeing more and more, because a lot of times this TG is probably a function of time after transplant. You start to see this lesion and now you're backtracking that, okay, if this is due to AMR or this is just like kind of, a function of time kind of a lesion. But I have seen those things, and whether you treat or not treat, I haven't seen much difference in those patients. I think they just need to get ready for the next transplant. And the question is, do we expose them to, like very high immunosuppression now, or just kind of let the jets cool off, put them on dialysis, go for the next transplant?
I guess, continue.
Okay. Can I have a question or a discussion going on?
Aves, go ahead, please. I'm sorry, there was two people on at the same time. So Aves, go ahead, please.
Okay, so, it's not like to AMR, just about rejection as a whole. So this Natera, the company, they came out with some blood test to detect rejection Prospera. What do you think of utilization of this? I mean, can I order that test? I don't take care of the transplant patient when they have suspected rejection. I just send to transplant center. I don't take care of them. But many patients, doctors like me, I mean, can they order this test when the creatinine goes up a little bit high on patient on transplant? Any utilization of this?
Yeah, so for people who are not familiar with these tests, this is cell-free DNA of donor origin. So what we can do now is we can draw a vial of blood from the recipient and evaluate them for their own DNA, as well as cell-free DNA, as well as cell-free DNA that is allo, that is from the donor. And the way you can do that is you can look at single nucleotide polymorphisms in the self-DNA and in DNA which is at variance, and then with a very, very high degree of confidence, figure out how much of the cell-free DNA is from the recipient and how much is from the donor in that blood sample. And so the idea is that if the allograft is in distress, then the amount of cell-free DNA in the circulation from the donor will go up. And if you get that high level of cell-free DNA, then the conclusion that you draw is there's something going on, and higher levels are more highly correlative with rejection. So yes, you can use these tests for surveillance purposes. So let's suppose you've got somebody who is 3 years out, and you're seeing them for their annual visit or every 6-month visit, and you draw a Prospera test. Prospera is Natera's test. There's another company, CareDx, which has the test called by the name of AlloSure. And in full disclosure, I'm one of the consultants for AlloSure, so I need to make sure that I make that disclosure. I did not do this upfront because I didn't think we'd be talking about cell-free DNA. But in any ways, if you do the Natera test and the Prospera test, and the cell-free percentage is high, then that is a time to pick up the phone and call the transplant center and say, hey, there's something going on with this guy. Maybe you want to take a look at them. If you are not taking care of these transplant patients beyond routine maintenance, if you're taking care of these patients, then obviously you want to check for a donor-specific antibody at that time, check for proteinuria, check for kidney function trends. And if those trends are not favorable, you may want to biopsy. If you remember the 4th case that I presented, the young lady who was completely pretty much normal, but her cell-free DNA signature was high, that patient We diagnosed with her microvascular injury due to angiotensin 1 receptor antibody, just because her cell-free DNA signature was high. Does that answer your question?
Yes, quickly. Do you use this test also in transplant center, or you don't? You just go directly?
We do. So I use cell-free DNA both for surveillance as well as in diagnostic situations where the creatinine has gone up. I'm not sure what's going on. I also use it where somebody has got, for instance, BK nephropathy and their immunosuppression is being modulated. So I check this test from time to time to see if the cell-free DNA signature is going up. And if I find that the cell-free DNA signature is going up, that is my cue to do a biopsy, because I then worry that either they're developing BK nephropathy or they've got breakthrough rejection.
Thank you.
Dr. Irfan?
I think Dr. Afzal had a question. Yes, please.
Yeah. First of all, a wonderful presentation as ever. Thank you so much for taking the time out. I wonder how you make such a big, elaborate presentation, and that takes a lot of time. Thank you so much. Now, coming back to the question, we were talking about C4D, and the origin of that was C4D is just a pointer towards C1q. So we are looking at C4D. Is it because the C4D is more, it tends to stick to the epithelium for the longer period of time, and that's why we do it? Or C1q, as it is present in lupus or C1q nephropathy, even if there is something called C1q nephropathy, but C1q, when do we want to see C1q and when do we want to see C4D? I'm just talking about the immunohistochemistry. We can go outside transplant too, just for an understanding, like the differentiation between C3 nephritis and post-infectious GN. There is Mayo Clinic study which helps to differentiate between the two if there is some kind of confusion. C4D is positive in post-infectious and it's negative in C3 nephritis. So how is that C1q and C4D different in terms of its presentation and diagnosis in different diseases?
So, so you ask two different questions. So let me answer the first one first. So it depends on where you are, right? So essentially what happens is that in conditions like immune complex deposition diseases, lupus is the flag bearer for that. Those antigen antibody complexes are formed or are deposited in the mesangium, right? So that's where they are. That's where the fixed complement, which is just sitting there. And so if there's C1q seen, that's seen in that mesangial area. So when Dr. Latif reports C1q positivity, it's in the glomerulus in the mesangial area where your antigen antibody complex is. In contradistinction to that, this process is an endothelial process. So essentially the antibody is going to be stuck on the endothelium and you're not going to catch it, catch the C1q when you stain for it. So that is why there was the need to develop an alternative technology, and C4D, which you correctly mentioned, is a product of C4b, which is a breakaway piece from C4. So the C4D is actually stuck onto the endothelium by a thioester bond. So it actually sticks to the endothelium. So when the specimen goes to Dr. Latif and she puts it through whatever pathology does in their big boxes in the lab, the C4D is still stuck to the endothelium. It's not fallen off. So she can actually stain for the C4D and see that. Aurangzeb, could you remind me what was the second question?
It was just regarding the understanding of the utility of C4D. Like we use C4D in order to differentiate between C3 nephritis versus post-infectious glomerulonephritis having C3.
Right. So essentially, when you've got C4D depositing, the thing that you can say is that the classic complement pathway has been engaged. That's all you can say, right? So if you've got C3GN, right, which is because there is a hyperfunction of the alternate pathway. The alternate pathway goes from C3 and using factor B and properidin and all that makes the C3 convertase without ever needing C4 or C2. And therefore, when you've got alternate complement pathway activated, all you're going to see is C3, C5, and MAC. And so you're not going to see C4D. So if you're just seeing C3, as is the case in the spectrum of C3GNs, the conclusion you draw is this classical pathway is not engaged and the alternate pathway is engaged. And that's what the reality of those disorders is.
Thank you so much. So one second question is, regarding the utility, there are 3 legs to the treatment. You have talked about the AMR treatment. One is we go with the plasmapheresis and IVIGs, and then we target the factories of antibodies, the plasma cells, right? Let's suppose we are in a center in Pakistan where we don't have rituximab and bortezomib isn't available. What is the utility of steroids for knocking out plasma cells? Is it dose dependent? The degree and the dose of steroid is going to decide if we are able to get rid of plasma cells or not, or as a monotherapy of steroid against plasma cells? What's your comment?
Yeah, so, our entire experience is based around the concept of removing circulating antibody. I can't recall a study which compared steroid monotherapy to plasmapheresis-based regimens, because that would be considered not providing the patient standard of care. So that would be hard to answer. Theoretically, steroids do lead to plasma cell depletion, but I don't know if steroid monotherapy alone is going to be helpful in the pre-existing antibody models. In those cases, you will have to remove the antibody. And truly, if these tools are not available, then you will probably want to be very, very, very careful in what risk you assume in transplanting these patients. Now, for the late ABMRs, if you draw a line through the people who are going to have ABMR or DSA and those who are not going to have DSA, that line is actually a Prograf 12R trough level of 7 nanograms per ml. So if you can keep their immunosuppression at a decent rate, a decent range, then your risk of developing donor-specific antibody goes down significantly. But I hear your problem that these are real life problems. You want to give them something, but if the patient says I'm not going to be able to afford rituximab, then you have a little bit of a problem there. Although rituximab doesn't appear very, very strongly in my books in the pre-existing antibody module. I use bortezomib quite a bit in these, especially in the less than 30 day. And we see a little bit more of these because of desensitization programs. So the only places where you're gonna see these early acute AMRs are, either if your pre-existing antibody generated an anamnestic response, or you desensitize somebody. And, so if you're desensitizing somebody, that they've got that antibody and that will jump. So after desensitization, you have a 25 to 30% AMR rate. And those are the patients where I use bortezomib quickly, plasmapheresis, IVIG, bortezomib, 1 or 2 cycles, and they usually steady up. And again, those kidneys heal up, and we've got over the past 10 years, I've probably treated 8 or 10. So this is not very common. And this is, having worked with programs where there's very heavy desensitization programs ongoing. Availability of appropriate drugs and diagnostic capabilities are definitely practical problems that you have to live with in Pakistan. But I think antibody-mediated rejection at this point, I can't say that steroid monotherapy is going to be highly effective.
I want to point one more comment from my Pakistani colleagues also, that as Irfan one slide very beautifully pointed out, the prognosis of the type 2 AMR is very, very poor as compared to the type 1. And the response to the treatment is also were because of the continuous non-adherence, which I see in Pakistan, is that the lesions already has become to the TG point, and it is a point of no return usually. And you just have optimization, is to optimize the therapies in these patients, and the CNIs are usually the key in these patients. Cell-sept Pakistani population cannot tolerate more than 500 milligram BID. One question regarding Dr. Aurangzeb's point of giving steroids. I've seen a lot of practice here for patients coming outside that whenever there is a jump in creatinine, their patients received a pulse methylprednisolone. I think it is not right that we don't know the cause of the acute kidney injury and we give pulse methylprednisolone to this patient, because these pulses are not without any harm. They will not cause anything for 1 to 2, 3 months like that, but after 2 years, it will appear in the brain as cryptococcal meningitis. So these practices really need to be modified. The patient has to be given the treatment according to the diagnosis, and precise therapy needs to be administered.
Okay, so there's a couple. That's a very well taken point. That's a very well taken point, Adil. So there's a couple of other questions. Any role of ATG in ABMR? That's Dr. Balig Mufti. Yeah, so not in the pre-existing pure antibody paradigm, but yes, when you've got late ABMR and there's a cell-mediated component, I have used ATG to dampen the immune response quite frequently. So I have a low threshold to do that. But again, you have to look at the entire cycle of the patient, their risk, their infection risk, age, yada, yada. And then another question from Dr. Balig Mufti is, can other types of injuries such as a urinary tract infection raise cell-free DNA? That is true, it can. Severe ATN can increase cell-free signature. Severe pyelonephritis can do that. Anything that's causing damage to the allograft will increase the amount of cell-free DNA from the graft that is getting into the circulation. So again, like any other test, that has to be interpreted in the light of all clinical information that is available. Any other questions? So how are our colleagues in SIUT treating ABMR? What are your practices and what are your experiences? Is there somebody?
Well, we're lucky that we have all these what that you were describing. We do the C4Ds, and we have bortezomib, we have rituximab, we do plasmapheresis. So all those 3 cases that you described, we would have treated them similarly.
Very good, very good. So you guys are always state of the art. Very impressive. Okay, any other questions, concerns before we adjourn? It's been about 2 hours.
So one last thing regarding IVIGs. You mentioned a dose of 2 grams per kg as a single dose. Is there any chance of any hyperviscosity syndrome, or was it reported in a side effect of that? Because the dose is usually used in a load sense.
Yeah, so the 2 gram per kilogram in a single dose is the Sader's protocol for high dose IVIG, and they have a very good experience with that. I don't know of any hyperviscosity. The only thing that you have to be careful about, especially when you're giving such a high dose of IVIG, is to select an IVIG formulation which is non-sucrose based, because if you pick up a sucrose based IVIG, it can actually lead to osmotic damage. And then your patient will have an ATN, and Dr. Latif will report to you that she sees vesicles and vacuoles in the proximal convoluted tubule. And that ATN can last, for some days after that. So we've had that own goal happen a couple of times, and now we have gone away from using any sucrose-based IVIG, and we use non-sucrose-based IVIGs. But other than that, I don't recall any major issues Anybody else on the call who've had other experience otherwise?
Yes, sucrose-free IVIG, unfortunately, Irfan is not available. So we are just using hydration and that's all.
So you have to be very careful using the high doses.
And because the institution is supporting these medications, the cost of IVIG for a 70 kg person is 11 lakh rupees.
Also, we increase the time, increase the IV fluid and increase the time between, the time for infusion.
Yeah, that's very important. Very slow.
Very slow. Irfan, I have a question. So I have a patient, I think you mentioned this, who is on dialysis and patient has a donor for kidney transplant. So patient had COVID, recovered from that. Obviously he has some antibodies. So how long you would, suggest to wait for that patient before he goes for transplant?
Yeah, so you ask 10 different centers, you're going to get 10 different protocols for that because we're all already PhDs in COVIDology. But the answer is, everybody has developed their own little thing based on just Gestalt, essentially. What we are doing at our center is we wait in a completely asymptomatic patient. We wait 4 to 6 weeks, repeat the test. If the test is negative, we go forward with transplantation. If somebody was symptomatic, we would wait 4 to 6 weeks from the time that they were completely asymptomatic and then check a test. Now, this does trap some of the patients who've got this low-level nasopharyngeal PCR positivity. But at our center, we were not feeling brave enough to transplant somebody and deplete them and yada, yada when their nasopharyngeal PCR is positive. So we are requiring a negative PCR test. It's not based on any science. We don't know whether it makes a difference or not. We're mostly treating ourselves like most of us are when we are treating COVID. Anyways, all this, the antivirals and the hydroxychloroquine and then Disaware. Eventually, all of us will die down once we vaccine and realize that, most of these had marginal benefits at best. We don't have a dramatic treatment for the disease. And that's a concern as well, that you have somebody over which, you have no steering wheel and brakes on a disease, and you give them thymoglobulin, now you've got the much bigger problem if the disease flares up. So we have to be careful.
And you will wait for the recommendation as far as the vaccine is concerned before you, suggesting a vaccine for the patient, kidney transplant patient.
Yeah, so I think we have to, people who've got, who are immunocompromised, who've got kidney transplants tend to do quite poorly with bad disease. I've lost 2 patients thus far to COVID-19 infection. No, 1 patient. 1 came pretty close, but they made it. So 1 patient to COVID-19 infection, but many centers have lost more. My feeling is based on a couple of observations, and I'm trying to parse my words very, very carefully here. So this is me, my personal experience and observations, that people with kidney transplant who get COVID infection tend to mount an antibody response. If you check their antibodies, you see IgGs and IgMs come up after a few weeks. They do clear it. So most of the transplant patients, like most of the general population, clear the virus like everybody else. So based on that, you say, okay, what would happen if I gave them the vaccine, right? So the risk with the vaccine is, okay, if you have a very high cytokine signature, right? Would that recruit an alloimmune response? Sometimes, 20 years ago, we used to worry about the same issue with flu shots. If we give somebody flu shots, would that lead to a rejection? Sometimes it does, very, very rarely, but mostly we say everybody should get a flu shot. So at this point, I think the risk to the patient is such that it might supersede the theoretical risk of recruiting an allo response, because an allo response I can take care of. I can give them steroids, but if they get bad COVID infection, then I don't have either a steering wheel or brakes on that disease. So that's the way I look at it, but that's me, my anecdotal experience. I don't think anybody has seen vaccine data on transplant patients. So it's an unknown.
Yeah, so I had a patient who was scheduled to get a living donor transplant, and the 24 hours ago before the surgery, his COVID was positive. So, and you know, the center has delayed him. It appears indefinitely. I mean, they're doing a test. His test is negative, but I think they're so scared to bring him back right now. So
yeah, I think that's an overreaction as well, because, you know, 2 or 3 things. Very, very few people get a reinfection. Some do, but most people don't get a reinfection. And the antibody is protective at least for 3 months. I mean, between 3 and 6 months, some of these patients lose antibody. But for about 3 months, I think there is some protection that is given. So if they are negative and completely asymptomatic, and it's 4 to 6 weeks out, and there's, you know, the PCR is negative, I might transplant the patient. I'm actually in a very similar situation, and we have decided to transplant the patient after about 6 to 8 weeks, making sure that their PCRs are negative.
Irfan, will you do a CT chest and a PFTs for these patients, asymptomatic recipients awaiting transplant?
Not really, not if they're asymptomatic. I mean, we treat them just as we would everybody else, because if their PCR is positive, we are not going to mess with them. So we have to make sure they're completely asymptomatic and their PCR is negative, and that's when we transplant them. So we don't transplant them if they're symptomatic at all.
I think some centers, like I know our center was doing CT chest for some elective surgeries along with the PCR. So this protocol has been utilized.
Yeah, so different people, different centers, you know, across town, there are different transplant centers that are doing all different things. And this is, you know, personal preference, but I really feel that if somebody is symptomatic in the least, they should not be transplanted. And the only people, and I want to be very, 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 very careful with this, the only people I would transplant who've had a COVID infection is those who are completely asymptomatic, who've cleared the virus, and they look great. And it has been 4 to 6 weeks at least since the time that they've cleared it. So those are the people I would bite on, not everybody.
Okay, so we are on top of the hour now. So maybe can I pass the motion to adjourn? Or maybe
one more time. So thank you. I really enjoyed it. I don't have much knowledge about the transplant. I learned a lot. I'm sure many people do. Thank you so much.
You're very welcome. It is my pleasure. Very good to be with everybody. So we'll see you next month. I don't know what we're doing next month, but I'll look it up and we'll be ready.
Thank you.
Take care.
Thank you.
Good night.
Dr. Irfan, so nice of you. Thank you. Assalamu alaikum.